It's a presentation that attempts to summarize a journey that I went through for the last 19 years. So there's quite a bit of contents, but I've tried to be synthetic and to extract key messages. We have the room in the conclusions to explore some of those messages. So the journey started in 2002 when I was doing my PhD at CERN at the European Organization for Nuclear Research. And we were looking to develop the first system to exchange personal data in the context of breast cancer, and more particularly in developing new algorithms for detecting various forms of cancer. And so by that time, we started pioneering and exploring the possibilities of connecting hospitals and researchers so that they can access enough data for doing their research works. What you see on the picture is the first workstation for screening that we had developed and that we had deployed in 3 different hospitals in Europe that were connected through the internet and more specifically with the grid that was making possible the exchange of data, and in particular data coming from 1,200 patients with about 8,000 images. So that first collaboration took place between 3 countries and 4 hospitals. And at that time, back in 2002, the first challenges we've been facing were first, digitalization. By that time, there were no mammography scanners, nothing was yet in place, technology was just coming, so we had to equip the hospitals with the proper scanners. And the scanners were outputting different data, so data was different in terms of quality and was not really comparable. So we've come up with, at the time, an interesting algorithm which was called the standard mammogram format, SMF, that was helping in harmonizing the various parameters of images so that they can be screened, compared, and above everything else, they can be analyzed. But that was the first challenge, not even speaking about privacy. We had started at that time working on various security and basic, I would say, privacy measures, so to not compromise individuals' identities. The second interesting experience we went through, and which was of a larger order of magnitude, was Healthy Child, which was about pediatric diseases and personalized medicine, where we connected 9 hospitals in 7 countries. And in that study, we could gather the data of more than 50,000 patients for about 19 million clinical variables. There, we started digging into the privacy basics. So we had to work on more advanced privacy measures, such as data masking, so to make sure that data, once it is collected, goes through a first level of anonymization before it gets shared with the rest of the network. What you see on the screen are a few pictures of the installation we went through. So we had a number of servers that we pre-installed, pre-configured, that we shipped to the hospitals, and then we installed there. And then we gave training to the physicians and the researchers to access. And at the time, we were already using electronic identities to authenticate and authorize access to the data. That's what you see on the picture bottom left, with USB dongles. With this experience, we went through a number of following chapters, which led to 2018, which were aimed at further extending the network and gathering more data. There, we faced a number of privacy-related problems. We had a few, like I mentioned this morning, like case report forms. We had to provide the physicians with means to digitalize the case report forms. At the beginning, it were mainly scans. We discovered that physicians didn't know much about privacy, and they were kind of faking anonymization by blanking areas in the PDF, but they were not doing it in a professional manner. So we had to help them with that. So basically what we did was to provide them with anonymization software locally installed to the hospital that was helping solving these problems. Other issues we've been facing with were related to professional manufacturers of information systems like Philips, IBM, that were providing them with the PACS servers for hosting the medical images. which were making it possible to extract those images with anonymization. But as you may know, DICOM, the standard, leaves, in some areas of the standard, leaves the freedom for manufacturers to store whichever information they want. So we ended up with a number of DICOM images that were still containing personal information, whereas they had gone through anonymization from systems like Philips CVIS or IBM Carestream servers. Another example on the right is an echography, and on echographies you may have also personal data on the images themselves. That's what you see in the upper area. So we had to develop software to basically blur or blank these areas even in the images, in addition to processing the DICOM tags. The third experiment I want to refer to is a new grid that started in 2008, and that's more about neurodegenerative diseases, where we provided a distributed environment for researchers to develop new imaging biomarkers for diseases like Alzheimer's. So it's a collaboration that involved 5 hospitals in 8 countries. 40 mining toolkits were integrated to the system to help them with developing new imaging biomarkers. And in the end, we could gather more than 118 data sets and carry out 265,000 analyses. Again, this went through a number of follow-up chapters that led till 2019, including one with the Alzheimer's Association in the US. And so we could gather more data and connect more centers. There we discovered that data is more and more complex. And sometimes you can get from the data more interesting information. And that was the case with MR scans. We were acquiring MR scans of the head of patients, so to run on the brain structure different types of algorithms to measure progression of diseases. You see some of them on the right. So basically, for instance, for Alzheimer's, we were measuring the cortical thickness, which is decreasing over time when you have Alzheimer's, because Alzheimer's is an inflammatory disease that literally damages the brain in certain particular areas. And so from the MR scans, what happened is that an educated IT person could reconstruct in 3D the face of the person. So for this particular type of data, we had to come up with proper defacing algorithms to ensure privacy of the involved patients. So throughout this journey, what we've noticed is a significant increase in complexity, heterogeneity, and volumes of data. And that was at the price of privacy, because at the beginning, privacy was more a security concern, and it was rather simple, like removing names, removing birth dates, and so on. But over time, we discovered that certain data types are making it possible to infer more information about people. So to address these various privacy-related problems, what we've been doing is to develop, as a first solution, privacy-enhancing technologies. So we've come up with a software that made it possible to define the identification profiles for different data sources. That's what you see on the screen. That would help then loading a local database, which we called a data capsule. And we would have one data capsule per data controller, so to speak, a hospital, for instance. What you see on screen is a data capsule access interface that gives you the possibility to query through a population of patients stored, anonymized, and stored in 6 data capsules, meaning 6 different hospitals. This was a problem as well, because we had to dig into data interoperability problems. We had to come up with a data model that would enable to follow up patients over time and have the different modalities of information attached to the patients, to the centers, and for the various studies. But in the end, we could gather an interesting set of cohorts, totaling more than 51,000 patients in Europe. And this system would have helped, actually, our researchers getting access to the cohorts and doing their research works. But these were the first, I think, research works that were really aiming at developing a so-called data marketplace where other researchers could go and ask an access for a cohort for their own research works. So the lessons learned from this almost 2 decades journey are that the healthcare data is complex. You have many different types of data, and every day you have new types of data coming in for new modalities, new devices. These data are heterogeneous. They are extremely sensitive. Most of the time, they are locked in proprietary information systems. I cannot recall the number, but we had several times struggles with IT suppliers that were selling software that did not even provide an API and a clear data model so we could extract the data properly. So we had to dig into and explore and find ways around to get the data out. And data is personal and evolves over time. And I think time is something we did not explore this morning, but it's something very interesting because the very notion of privacy from an IT perspective evolves over time, because over time regulation changes, technologies advances, and the data itself tends to get more complex. So as much as we had worked into providing sufficient security and privacy and developed software to help those centers getting connected and sharing more and more data, there is one thing we didn't work on, which was trust. We had this recurring problem of centers facing ethical boards and convincing our partners in getting connected and sharing their data for various reasons. And so we've come up with the feeling that we should try and incrementally augment what we had so far developed with something that would bring digital trust over the entire ecosystem. And when you step back a little and think about what's happening in Europe, Europe is working at materializing, making its digital single market true. And there is one important step that we are taking forward now that has started since 2019, and that is a strategic objective by 2025, which is the European health data space. I may not be aware of all of the national initiatives, but I can tell you that in France it is seriously taken up, and we have started with our own national health data hub, and this will be part of this European health data space. And I think we'll have at the end a federated European health data space that will connect all of the national initiatives. But to get there, our belief is that we have to liberate data, and to liberate data, we have to provide more traceability and therefore transparency. This digital single market is now regulated. You have the General Data Protection Regulation, GDPR, that applies on everything that is personal data, personal pseudonymous data. You also have the free data flow for everything that is non-personal. And this is, to me, not really a hurdle. It's rather a market that is opening. We know that personal data has a value. By 2020, personal data was expected to be valued about 300 billion. And we have seen from various examples in the press recently, but over the last couple of years, a number of data leaks that have had a significant cost. So in order to face that and to work on solutions that could help shaping that market and that could help us also take a stake on that market, we've been going through all of the regulations. What you see on screen is a digest of all applicable regulations from the Universal Declaration of Human Rights, going through the Council of EU Convention, the Charter of Fundamental Rights, the following DPD, EPD, OECD guidelines, and then GDPR surrounding everything. And that's an attempt to summarize those in major concepts and to map those with possible technologies. I will not detail it, and you have the publication, and by the way, in the presentation, every time you see this red caption, it's a key publication where you can find more information about what is presented. But basically, what is there, what this privacy compass says is that privacy is about, first, design. Privacy must be taken into account in the design of every single solution. Privacy is a condition that must be kept over time. So privacy by default, during the operation of your system, you have to keep this condition. And last but not least, informational self-determination. Data subjects have rights. So you have to make sure that your solutions make it possible for them to apply their rights. So out of this, we had worked on a number of, I would say, privacy basics and more related with data masking technologies and security technologies. We decided to gear toward two major axes, one being developing and making it possible to have full traceability, end-to-end traceability in the ecosystem. So we decided to go for blockchain ledgers. And the second was to work on possibly the legal automation, how to make these rights applicable, executable over an ecosystem. So we decided to work on smart contracts as well. That's why we created back in 2016 a project called My Health, My Data, funded by the European Commission, and where we have tried to develop a system that makes things accountable, responsible, in a multipartite, cross-enterprise, transnational, and decentralized manner, taking aboard all of the constraints we had faced in the past. And we wanted to have a transactional system that can evolve over time and that can organize the value chain to productize. So that's why naturally we've come to the blockchain that is the famous protocol behind cryptocurrencies like Bitcoin, which has a real added value for information systems and personal data exchanges, because the blockchain is a chain of blocks. Blocks are signed electronically, and they are stored upon validation of the network, and the network acts as a distributed and decentralized trusted third party. And so the blockchain brings you with resiliency. It brings you with a database that cannot be theoretically falsified, and that is immutable. But having said so, if the blockchain is immutable, that means that theoretically, if I have personal data into the blockchain, I cannot apply the right to be forgotten from GDPR. So the core of these research works in My Health, My Data consisted in producing, in imagining a new model of a blockchain that would be GDPR compliant, but at the same time would make us benefit from its added value in terms of traceability. And so we've been working on a core model using one-way crypto algorithms and making the bet that personal data would at no cost be stored in the blockchain. So we would keep the so-called trusted third parties like data controllers, hospitals, research centers, as the ones hosting and having full control over the data. But we would use the blockchain as an exoskeleton information system that would interconnect all of them and provide us with a data catalog and all of the means to organize data exchanges. So we would create, in other words, a network of trusted third parties. And so after a year and a half, almost 2 years, we've managed to come up with such a model. We've created a model combining 3 cryptographic algorithms, one demonstrating the existence of data in the consent. It's a proof of existence, top left. That's a fingerprint, a cryptographic fingerprint of the data and the consent that we use to register the data into the blockchain ledger. Then, once the data is registered in the blockchain ledger, it can be mobilized for a given processing purpose. And that processing purpose is wrapped into a contract, a smart contract. And the smart contract, when executed, provides a proof of matching, top right, which is the second cryptographic fingerprint that demonstrates that a given data has been used for by a given contract. And we wanted to go a little further and make sure that the resulting ledger, which would be in the end a GDPR processing registry, would be statistically non-inferable. So we've gone until redeveloping the consensus algorithm of the blockchain, so to get the proof of privacy, where we have been using zero-knowledge proof to hide the identities of the signatories of the servers signing the transactions. So in the end, what we've managed to achieve is a non-inferable GDPR registry where we have data and all of the usages of the data documented. You can read the blockchain as a human. You won't get anything. You won't understand it because it's mostly about cryptographic hashes organized and time-stamped. But with software, and in particular the trusted third parties in the network, they have the possibility, because they have a mapping locally to the trusted third party, to understand what their data is into that registry and where it's been used. Now, that was the first main step to develop a so-called GDPR registry that would provide us with all of the traceability of our data and exchanges and usages. What we wanted to achieve beyond this data marketplace, this federated data marketplace, was a system that would allow us, in the longer run, to value the data exchanges, but not to value only economically those data exchanges, because we don't want people to sell their data. It's not the point. We want people, institutions, to be paid for the price, for the costs incurred by maintaining an infrastructure, by curating the data, and making that data available. And at the same time, I personally wanted to explore the societal value of sharing data, what it means for me as an individual, for instance, to share my data for a given study. Is there anything that I can get from it, societally speaking, the value of it? And so, and back in 2013, I started an MBA, and as part of my MBA, I've been exploring the humanitarian funding research area. And there I've been coming up with a possibly new model for funding the humanitarian action, where there was this both valuation of economical and societal value of the action. And that was, as a research work, coming as an extension of the agency theory. The agency theory is the one that, that dictates the whole world we are working in, we are living in, and that implies a contractual relationship between two parties having different objectives. So I've come up with this model, and then a couple of years later, I started thinking, but basically, why not using that very same model for valuing data sharing? I mean, because the problem is the same. There is an economic value that has to be taken into consideration for maintaining data and making it available for various purposes. But at the same time, I would like to value the societal asset behind that data. So this is what we proposed as an exploration at the core of the My Health, My Data system, to develop a system that would help with valuing data exchanges, both economically and societally. So in our developments, what we did is to say we need actually two blockchains. We need one for the GDPR registry to have this full end-to-end traceability. And we need one to account, to measure, to account basically this value behind the data. So we've come up with an infrastructure where we can run two blockchains. It's a dual blockchain implementation. We actually developed this based on Hyperledger Fabric, which was at the time the most promising open source implementation of a blockchain that was sufficiently flexible for us to adapt, to modify, to make it fit for purpose to what we were doing. But it was not entirely ready for all of what I've been showing, so we had to do a number of improvements. So basically, we've been developing a trading currency that's using the PBFT settlement consensus that is cost efficient because PBFT is not like Bitcoin. It doesn't require a data center, a processing, a computational center to be part of it. It's really not, computationally speaking, demanding. So this is something that can fit within hospitals, within research centers, a single server, and that is the reason why it was our main choice. Second, we had to look into what's been done in cryptocurrencies. In cryptocurrencies, as they are dealing with a particular asset, a cryptocurrency, they have developed protocols for settlement, for payments, and so on. And the de facto standards in the area is ERC20. But ERC20 was not available on Hyperledger Fabric. So we've been the first developing an ERC20 settlement protocol for the Hyperledger Fabric blockchain. Also, our choice was motivated by the fact that our strong belief is that even though the blockchain is a trusted third-party killer, we are not at the point where we can kill the trusted third parties because we still need them. You have to have those third parties because they help you with dealing with parties that you cannot or do not trust naturally. We're not yet at the moment where blockchain can replace all of the central organizations in the world, from banks to insurances to anything. But rather at the point where blockchain has to penetrate the information system, has to take place, to extend and expand. And so we wanted to develop a network where we respect the presence and the role of trusted third parties. And so trusted third parties are nodes, actual nodes of our blockchain. And we kept that in mind to develop in the longer run the so-called value-based care. So with such a double valuation, making it possible to value the actual care. So our investigation has gone that far that we have built a cryptocurrency for using credits in that cryptocurrency, representing the infrastructure and the personal costs involved in making data available for the network. But at the same time, we have started exploring ways of societally valuing that data, starting from impact factor in scientific publications, so adding data, persistent identifiers, publications, so that data gets an impact factor valuation. The notion of data donor, being able as a citizen, as a patient, to revendicate my donorship of data to a given initiative. And eventually we thought about counting number of lives saved, maybe fictional, maybe highly theoretical, but having a portion of life saved thanks to data shared with research projects. So the system we've ended up with looks like this. We have data collection centers or data controllers that are equipped on the right with the software, the proper software to do pseudonymization locally. And then there is a so-called driver software that does the data registration, crawling, semantic mapping, so we can feed a data catalog, a global data catalog. And there is a second level of pseudonymization thanks to the proof of existence. So the blockchain only gets a pseudonym that is a one-way crypto fingerprint, and that is completely amorphous as soon as the data controller removes the data locally to the site. And on the other side, individuals, professionals willing to, or researchers willing to access the data, they have access to a mobile application where you can, as an individual, for instance, set up your consent, the duration of your consent, be notified for given research studies and volunteer for some of them, and a website from where the actual researchers can make requests to access different cohorts. And that materializes as a query interface, so to speak, where you only ask for medical terms. So it uses a medical terminology, UMLS in the present case, and that tells you if there are patients having a neurodegenerative disease like Alzheimer's, having MR scans or case report forms or genetics data, but it doesn't say more, where, who, what's inside the data more specifically, and so on. And this query is wrapped into a smart contract that is then executed over the entire blockchain, and the blockchain makes the mapping. So it looks for the data that you are looking for into every single node and figures out if finally you have those 150 patients that were in the global catalog and make them available. Here, an important aspect of our works was the notion of contracts, because we wanted to have contracts for individuals, contracts related with their GDPR rights, but we also wanted to have research contracts for isolated researchers, for consortia of research projects that could access for free or for the very basic costs of maintaining data available, access to it. And commercial contracts for pharmaceuticals, for instance, contract research organizations looking to access some cohorts. What's interesting in that work is that we've been going down the notion of lawfulness and exploring how much a smart contract could cover the legal requirements of a contract and basically the legal object and the consent. So this is the vision that code is law. Contracts are here to automate and help with the application of human rights, but also of business laws. So once this is done, the data that's been identified, located, is made available through a dedicated private cloud. Depending on the data typology, we may apply further the identification. If it is mainly tabular data, for instance, we can generalize a little more the data and make it a little more protected before delivery. So this concluded in a European pilot that we demonstrated at the European Digital Assembly, where we could demonstrate 4 hospitals connected live with 81,000 patients, and that was representing 71 million clinical variables shared at the time. We demonstrated data registration, data exchanges between different centers for a given processing purpose, and we got until the right to be forgotten by an individual re-identified in the network using the mobile application. So actually the mobile application looks like this. Maybe I have to click. Read. Okay, anyway. So using the mobile application, you would basically, as an individual, receive notifications to participate to given research studies. You could define your consent, provide a duration for revocation of your consent, and then you could agree with sharing your data by swiping in the application. What's interesting is that, of course, in having done so, we could gather sufficient data for our various researchers and research centers and companies involved. And these are just a few exemplars of applications developed on top of that network. You have bottom left a data curation interface that was developed by the University of Athens that helps basically cleaning up and creating new cohorts from the data that's available in the network. That's pretty neat because it's got all of the statistical tools graphically available, so you can remove outliers, you can arrange your cohort and make it available as a new cohort in the system. Bottom right is an application from HESO. in Switzerland that aims to help with querying through the population with semantics. So you can look for patient conditions using semantic terminologies and have the most, the most pertinent results. So each line is a patient, and it learns from your feedback, so it improves the algorithms over time. Then top right, you have a statistical application from Siemens that gives you a number of averages and calculations over the population in terms of morbidities and so on. Also, possible live comparisons of certain artifacts of the patient. In that present case, what you see on the right is a comparison of the left ventricle shape between kids that were having tetralogy of Fallot disease. So it was important for them, for the physicians, actually, to find other kids having similar shaped ventricles, so to understand what surgical operation to go for and have a look at the feedback from other physicians. And top left, which I think is the most interesting and where we are all heading to, is a deep learning-based application for finding out similarities between patients in the population. So here you can compare your own patient to the population and find the 5 most similar, but you can also find clusters of similarities and therefore discover new knowledge possibly out of those clusters. So coming back to that privacy compass, the next step for us is to work on risk assessment. So we have 2 new projects. In particular, one Curex that is about adding to what you saw, this blockchain system, adding cybersecurity and privacy risk assessment prior to validating any transaction, and that is done with dedicated software that measures locally to the site the risks and then produces a threshold, and depending on the threshold, we validate or not the smart contract execution. And one last project I will put the focus on is Quantumacy, which stands for quantum privacy, where we are with the European Organization for Nuclear Research, developing, where we are extending this platform, so using the blockchain and trying to have CERN as a major site, because they would like in the long term to have their employees share voluntarily their medical data for medical research. So we are developing on that platform. It's a living lab that we are developing together that we have proposed to the OpenQKD consortium, which is the largest European project to date aiming at deploying the quantum key distribution enabled network. So quantum key distribution, for those who do not know, is one of the first applications of quantum physics. We are using quantum decoherence to make sure that data cannot be spied. You cannot have a man-in-the-middle attack because we are using specific fiber routers that are entangling photons. And when the photons are entangled, if someone measures the actual state of the photon will change of state. And this change of state will falsify the communication. So it prevents from a man-in-the-middle attack. And they are testing it at the European level with different exchange points. And they asked us to be the first pioneer use case for personal data exchange using that network. So we are presently developing a particular data transfer protocol that leverages on quantum key distribution to further secure all of the exchanges between the points. So to conclude, so these works have been rewarded a few times by the European Commission at ICT in 2013, by the United Nations at the Global SME Award in 2016, and more recently as part of the Innovation Radar. Just to conclude, technically and organizationally, so the blockchain is not a real database. It's not really performant. It cannot handle loads of data. It's just good at handling traceability data. Data stored in the blockchain is immutable, so you have to take care of it whenever dealing with personal data and the right to be forgotten. The blockchain is by far not the ideal solution. It's only one component of the ideal solution. I did not present it because I didn't have time, but in the experimentation in My Health, My Data, we've been combining a number of things. Depending on the processing purpose, we've been using SMPCs for local computations. That was done by the University of Athens. We've been using synthetic data for testing the system at large scale. So we did it with BARTs in the UK. They have been with AI creating large synthetic data sets based on the actual raw data that we got from the various centers, so to have something sufficiently representative to test the system. We've been using data masking technologies, the blockchain for the traceability, and we even explored homomorphic encryption for some very, very specific analysis with Siemens. So the blockchain is just one component. It's one big and important component, but it's not the only one. And the blockchain does not scale. Still, to date, it still has problems with scaling with more than 1,000 nodes, and therefore, when it will come to generalizing the blockchain, we'll still have this problem to solve. Organizationally speaking, we had the opportunity this morning to discuss it, but I think that COVID-19 has significantly accelerated digitalization worldwide, and I think it was even better for standards adoption. I think that standards, we are no longer much lacking of. Now we have to abide to the standards, which is still a bit of work for a number of institutions and centers, but it's there. The European Health Data Space, with its objective to federate all of the national initiatives, I think could benefit a lot from using the blockchain as a common and global registry or data catalog. Another point, an important point that we also figured out with time, and that relates more with the actual exploitation of a resulting blockchain, is that despite the fact that this is distributed and that you have smart contracts that are distributed applications, you still have by laws the need to define a single data processor that is legally responsible for the smart contract execution. That's why most of the blockchain initiatives end up with the creation of a startup, because you have to have this legal representative. The blockchain, as I said, removes or aims to remove trusted third parties, but it implies at the same time putting all of the stakeholders of the ecosystem into it. So you cannot remove the trusted third parties now. You still have to cope with them. And this one is very important because everybody is excited about the blockchain and wants to run the blockchain for everything. But the blockchain needs you to rethink the business model and the ecosystem. It's not a single person or a single institution work. The blockchain does not provide you with much if you are not doing that in an ecosystem with all of the parties represented. So you have to think about the value chain as a whole and rethink it, because you have to find the incentive for every single stakeholder to get in. And that's about it for my conclusion. Thank you.